let's jump to anxiety disorders. I get a lot of questions about the benzodiazepines for the treatment of anxiety disorders. What say you? I see Xanax. I see Klonopin a lot. Those are, I'll put down the most common. So those are probably the two most common ones that I see. First, are there any other ones that are used more commonly in pregnancy? And then generally, what do we know about the benzos in pregnancy?
I'd say Xanax, Ativan, and Klonopin. Yeah. Those are probably the ones that I see the most. Well, so I feel like I'm a little bit biased about benzos because I don't like benzos. And like I'll see patients who have been put on them for anxiety, and they're taking them, you know, multiple times a day, every single day. And they really, you know, in terms of long-term use, have a lot of evidence that they increase the risk of dementia and just aren't good for your brain long-term. So I have a little bit of a bias against them. But in terms of their use appropriately in pregnancy, so mom's having panic attacks, or she's having really severe anxiety and can't function, and you need that to kind of help bridge her till her other medications working better. It's, you know, there's not really a lot of research saying that they're bad in pregnancy. There used to be some research saying that they might increase the risk of cleft lip and cleft palate, but that's been pretty much disproven. As long as they're taking them kind of as needed in the second and third trimester, there's really not much risk that's been shown there. I think when women are taking them every single day, multiple times a day, then that's when we get a little bit more concerned for the baby, especially, you know, when baby comes out and has withdrawal symptoms from it.
Yeah, and I would agree with that, because so much happens in pregnancy, and benzos can be taken multiple times a day. And if I see a patient that's escalating how much and is not getting simultaneous treatment, whether it's with therapy, you know, then I start to become concerned that they maybe they're relying on the medication, and not that they're doing it purposely. It's just that things change. Pregnancy is not easy. The benzos do work. And if you're taking them up to 4 to 6 times a day, it's easy just to escalate that dose. So we, as providers, if we have patients that are on them, they need to be taken only when needed. If you notice that there's starting to be an escalation, what I've seen a lot, and they're going through their scripts quicker, then we need to, you know, ideally they should already be seeing a therapist or a psychiatrist. But if they're not, then they really need to, because it could be that they just need to start getting through that therapy, and they don't really need the medications. And again, I don't think that they're doing it on purpose. It's just because it's there, and they know they can take it multiple times a day if they need to. Is that your general experience? Have you seen that happen?
Yeah. I mean, they're a type of medication that we automatically build tolerance.
Probably not, but we might need to. We might need to, because it's hard to tell a patient, you know, you need to stop taking your benzos, or you need to cut back if that's what they've been relying on. So we have to look at the whole picture there. Somebody had asked the treatment of acute anxiety attacks. Somebody has anxiety disorder, then they have an acute anxiety attack, or is it the same thing as a panic attack? Is that interchangeable?
I think for most people it is. I mean, technically, clinically, it's called a panic attack. And there's a very specific, you know, criteria and stuff for it. But I think people use those interchangeably.
And then, so how would that be managed, or would it be managed any differently?
So if somebody's having panic attacks regularly, or they're having them, you know, somewhat frequently, then it's usually recommended that they do therapy, or they start on like an SSRI type medication to help the underlying anxiety that's going on that's triggering these panic attacks, and then taking a benzodiazepine when the panic attack happens, if it's, you know, lasting a long time and is really impairing, or using like meditation or breathing exercises. Those can be just as helpful for some people.
Yeah, so and every individual is going to be different as far as how that's best managed. But what I don't recommend is, especially someone that has anxiety, a history of panic disorder or anxiety disorder and panic attacks, is just waiting until it happens. I'm not gonna, I don't want to take anything. And again, cross your fingers and hope that you don't have that panic attack. And then the next thing you know, you're in labor and delivery because you're in a full-blown panic attack. You know, just be on the maintenance medication to try to prevent that from happening. because people that have really severe panic attacks in an acute episode, that could be very problematic in pregnancy and hard to treat. And then you end up getting a bunch more things to treat it that you probably could have avoided if we had just managed, you know, had you on something all along. And I see that a lot with patients who want to avoid taking anything. And I get it. You know, I've been pregnant. I know you don't want to expose the baby to anything that you don't have to, but you have to think about the consequences of not taking it, and what is you know, having serial panic attacks going to do to the pregnancy. And I've seen that as well. Have you seen that too?
I've seen that, and it's, you know, there's even research to show like panic attacks and high anxiety in pregnancy, and it's just, you know, it's not good for the baby and for the pregnancy. And
I mean, I've even had patients come in that I thought were having severe preeclampsia because their blood pressures were so high, but it really was just a bad panic attack. And they're two very different things, right? And, you know, a severe preeclamptic with severe ranging blood pressures could need delivery, whereas a panic attack and your work, you know, the blood pressure can be high because of that. It's different. So, you know, just if you have a history of having anxiety disorder and a history of panic attacks, just get on the medication that keeps you stable throughout to try to avoid those intermittent, really full-blown panic attacks. Would that be your recommendation as well?
Yeah, I mean, I think for some people, I think they can manage it with therapy too.
And yes, therapy.
Similarly with depression. Yeah. But yeah, it would be, you know, finding the treatment that has worked for you and doing that in pregnancy, because a lot of times those anxiety disorders, just like depressive disorders, get worse postpartum too. And that's a time when they can relapse in those.
And since you brought it up, this conversation is about medications in pregnancy. I'm not saying medications without therapy. I truly believe that should be go hand in hand. So that we're just talking specifically about certain medications, but I'm not saying that we'll just take this medication and avoid therapy. Absolutely not. We still need to be making sure our patients are in therapy of some sort, in you know, consort with the medications. The last thing I wanted to